My name is John Lumpkin. I'm with the Robert Wood Johnson Foundation. And, as part of a clinical career, there are cases that you remember for a long time. One of these cases was one that I had when I was a senior medical student. It was a 16-year-old gentleman who came in, and I was seeing him while I was doing an emergency medicine rotation. He came into the ER, he was complaining of upper abdominal pain and low blood pressure. So thinking that perhaps what we had was an intra-abdominal catastrophe, we put in an IV, we sent him off for x-rays, we drew blood. He came back an hour and a half later, his x-ray was unremarkable. And so his blood pressure was still low, and he was still having abdominal pain, so we continued with the fluids. At this particular point in time, my shift was over. So I left. When I came back the next day, the attending said to me, "Remember that patient you saw yesterday with abdominal pain, the 16-year-old? Now, there are very few conversations in the emergency department that end well, that start with, remember the patient that you saw yesterday." As it turns out, this 16-year-old man had an abnormal coronary artery, and in fact what he had was a heart attack. And his blood pressure was low because of that. It wasn't low because of something bleeding in his belly. And giving him fluids was the wrong thing to do. And clearly, I had made an error in judgment. And as I was thinking about this, this is the kind of case that comes back to you. And as I was facing challenges in my career, whether it was initially in emergency medicine or public health, and then into philanthropy, I would come back to this case and think about how these decisions were being made. And what could I do to restructure decisions? And I recognized that in medical school, I was ill-prepared, and I wasn't trained on how decisions are made. Decision science has gone through a major transformation over the last few decades. And as we begin to understand how people make decisions and how they think, we begin to look at how they interplay. Daniel Kahneman, who's a psychologist who won the Nobel Prize in economics, describes the different ways that people think as fast thinking and slow thinking, or deliberative thinking. When you think about fast thinking, this is a survival characteristic. You're out in the savannah, you see a lion, you hear a lion, you want the memories to come to mind to tell you how to respond to this emergency and to get away. But since the development of culture, man has had to take another approach to thinking, a deliberative approach, to create works of art and tools. And it's this interplay between this older fast thinking and the slower deliberative thinking that plays an important role in how decisions are made by us as clinicians and by our patients. Fast thinking is quick. It's responsive. It draws memories that enable you to respond to an emergency. Slow thinking is deliberative, and it's hard, and it's exhausting. Let me give you an example about that. Okay, what's the answer? Everybody knows what the answer to that is. 3 times 3 is 9. And if I change the problem a little bit and I say 4 times 3, everybody knows that's 12. Okay, quick, what's the answer to this one? 127 times 54? Did you feel the change in your brain as you saw that problem? All of a sudden it went from, I know the answer, to I have to think about that. And some of you tried to calculate in your head. Some of you may have thought about getting a piece of paper and a pencil or maybe a calculator. But probably the most of you are saying, this is just too hard, I'm not going to worry about it, and I hope he doesn't call on me for the answer. That's the interplay. Slow thinking is deliberative, it's hard, and people tend to shy away from doing it. Our brain defaults to fast thinking. Now, we use this difference in thinking in clinical science. We use it in everyday life. We memorize our multiplication tables so that we can better understand how to draw in math facts. We also use it in clinical work where we memorize medications and we memorize algorithms. You don't want to be trying to figure out the next dosage when you're managing a cardiac arrest. You want to have that as part of your fast thinking. But we've also learned in healthcare to change into deliberative thinking when we need to do it. Now, how many of us of those, the clinicians in the room, and there was an orthopedic surgeon at my table, I think, You don't put up an x-ray of the neck and just look up and say, Gestalt, hey, it looks normal. No, we've learned to take it in a very deliberative way. We look at the alignment of the vertebral bodies. We look at the soft tissue in front of the vertebral bodies to look for swelling, to make sure that there might not be an injury that doesn't really appear apparent. We understand that we have to slow down our thinking to assure that we get the best patient outcomes. That's why checklists work. They slow us down to make sure that we hit every single step in the process. Now, one of the problems of slow, fast thinking is sometimes we don't pull all the memories in place. That's why checklists work. But another problem with fast thinking is the fact that it's persistent and it can be dominant. Now, many of you have seen this before, and immediately as soon as you look at it, when I ask you to compare the length of the dark lines, most of you are thinking, with the fast part of your brain, the one on the right is actually longer. And then the deliberative part of your brain is saying, I've seen this before, and I think they're both the same length. And in fact, if you measure them, you'll see, in fact, they are the same length. But let me take that away and bring it back. And once again, the fast part of your brain is telling you, the one on the right just looks longer, even though you know that it's not. This is why it's very important for us to think about ways to structure our decision making. Because if we rely upon the fast thinking, if we don't pull all the facts at hand, we run the risk of making the wrong kinds of decisions. One of the errors in fast thinking is called representativeness. So what that means is that we see something and then we apply the characteristics of a group to it. Let me give an example. When you're talking with a patient who's a candidate for a liver transplant, you need to understand whether or not they have the social support structure and whether or not they have the capabilities to follow through on the very complex therapy that's required after a liver transplant. One of the ways is to have an encounter with the patient. And if the patient looks like this, looks like a homeless person, you're less likely to say, I'm going to select that individual for liver transplant. But if the patient looks more like this, with a tie and a coat, you're more likely to say that that individual is going to be someone who might be a candidate for a liver transplant. Representativeness means that you look at an individual and you ascribe to that individual a group. And then you apply the attributes of that group to that individual. And it may be that the group that you apply them to is based upon their race, based upon their ethnicity, based upon their appearance. Rarely do you base it upon the fact that the group is the Rolling Stones. And both of these individuals would be in a position to think about as a candidate, except for their hard drug use in the past, as a candidate for a liver transplant. We have to think about designing our systems in such a way so that when the decisions are made, that we're making them with our deliberative part of our brain and not making the decisions based upon the appearance of the patient, presenting all the facts at the time of the decision. Now, another characteristic of decision theory is called context, or framing an issue. And in framing, how the facts are presented and sometimes carry more weight than the accuracy of the facts themselves. Let me give you an example. There was a study that was done by some of the Harvard psychologists, and they had a group of physicians. And they talked to them about treatment of lung cancer. Now, at the time the study was done, they compared surgery versus radiation. The 5-year survival was better for surgery. The short-term survival was better for radiation. And they talked to the physicians about the risk factors. Half of the physicians, they talked to them and they talked about the risk factors in the context that the survival rate for surgery was 90%. The other half of the physicians, they talked to them about the mortality rate, which was 10%. Now, we all know, sitting here, 90% survival, 10% mortality, it's exactly the same thing. But when they asked the physicians what would they recommend for their patients in this context, the ones who had the risk described as part of survival, 84% of them recommended surgery. But when they asked them, the physicians who were informed about the risk in the basis of mortality, only half of them said that they would recommend surgery. How we frame issues have a significant impact. They have an impact upon our patients, they have an impact upon ourselves. And when we are making those recommendations, we tend to default to the risks that we think are important, as opposed to the risks that the patients do. And that way we frame their decisions, sometimes in ways that they're not happy with. You heard a little bit earlier about Eric Dishman. He also heads up some of the work at Intel around health implementations, and I've known Eric for a number of years. He's actually a very amazing fellow. And he talked about his liver transplant. What you didn't hear, he talked about in the same tape, and I encourage you to go to Ted's website and listen to it, is that he began to realize, as he was being treated, that his physicians were giving him his medication based upon longevity. And what was really important to him was snow. And he worked with his physicians so that they adjusted his medications to maximize the amount of time that he was able to spend skiing. Because what was important to him was snow. The second thing that he said also in that presentation is very critical. He said, it dawned on me that the healthcare system treats patients as averages, not as individuals. And that really rang true with me when I thought about that 16-year-old young man who had come into my emergency department. And I said, on average, a 16-year-old is not going to have a heart attack. And the third thing he said, based upon his experience in technology, is that we should have the capacity to use big data to create predictive models for me and my care. So how might that work? Well, big data comes from clinical encounters, which, we used to put them into paper records, but now we're seeing increasingly the rapid adoption of electronic health records, and all this stuff is going into databases and data warehouses. Now, we have to be careful. Carr White, who was a data advisor to the Department of Health and Human Services, warned us in 1974 that we have to be careful we're not collecting masses of data untouched by human thought. Other industries have begun to use this data in very interesting and innovative ways. For instance, in the grocery industry. I shop at ShopRite. They have this little key card, and on the back of it is a barcode. So every time I check out, they swipe the barcode, and they know exactly everything that I buy at the food store. And I do it because I get a discount. And they do it because they can target me. And when I check out, they give me a coupon for tea because I'm a tea drinker. And they know that from how I'm shopping. Interestingly enough, the Obama 2012 campaign took this kind of approach of mixing this kind of data, of taking data from shopping and credit card data, and mashed it up with information they got from surveys and focus groups. And they used it to target voters. And they could build a predictive model that would say which were the people who are likely to vote for Barack Obama. And not only that, they could say which are the ones who could be reached by mail or needed a campaign worker to visit their door. When we apply the concepts of big data to healthcare, you can do things like looking for trends and identifying the fact that Vioxx has cardiac problems months or years before the normal FDA process could do that. When we take big data and we connect it with personal genomic data or proteomic data or any of the omic data, we begin to have personalized medicine. And we can identify medications and treatments that are personalized for each individual. I would argue that that's probably not good enough, that we need to take this a step further. We need to think about not personalized medicine, but personalized care, personalized health. If we can take what we can learn from big data and mash it up in data analytics about the care side, and then take all the data that you're collecting in Kaiser and hook it up with the context in which patients are making the decisions and the things that are important to them, you can begin to customize for each patient a care pattern that addresses not only what the medications you're giving, but also their response to that and what the likely outcomes are to be. And then linking those to the outcomes that are most important to them. Doing that, you could say that this particular individual is only 13% likely to follow and comply with all of his treatment if he's only given a prescription. And that the odds go up if he has a case manager. But based upon his context, he's probably not going to respond to having a group visit. And if you address his treatment outcomes to the things that are important to him, you're liable to have the highest compliance. Understanding what's important to the patients and the context in which they're making the decisions. Knowing what's important to them, whether it's having the opportunity to play with their grandchildren, or the opportunity to see their daughter get married, or reduction in pain, or just having the opportunity to spend more time in snow. Thank you.